we've chosen to take a year out of their usual working life to come and do fabulous things, to learn a little bit about leadership and management, but also to do project work as part of that learning for the year that they're with us. And we're today privileged to have all 5 clinical leadership fellows for this year telling us about their projects and the changes that they've made over the last year. And just to push the blue triangle like I usually do in these situations, we all remember that there's that single word at the top, which is patient. We've got our vision to be the best provider of specialised and integrated care, and we've got our strategic objectives. All these projects map into patients. So that golden thread I talk about continually is still there for all of these projects. So it's not 5 folks going off on one, it's 5 folks feeding into the agenda that we've got LTHT, whilst also hopefully learning about leadership and management during these projects. So without further ado, we'll take it as we normally do. We'll have questions at the end, so folks, get your pens and papers out to remember as we go through them. But I'd like to introduce Clodagh first. Clodagh, just tell folks a little bit about yourself before you go into your presentation.
Yeah, absolutely. Thanks so much, Magnus. I'm Clodagh, as one of the 5 clinical leadership fellows, and my background is an obs and gynae registrar. So the overarching aim of my project was to look at lowering perinatal mortality rate in the trust, which felt like a very big aim for one person in 1 year. So I focused then on perinatal outcomes in non-spontaneous preterm births. I had some help from the people that I've named here, who's a consultant obstetrician, director of midwifery, and some neonatal consultants. Next slide, please. So this is a screenshot from Embrace UK, which is Mothers and Babies Reducing Risk Through Audits and Confidential Inquiries across the UK. And we report, as well as all trusts in the UK, all maternal and neonatal deaths to them, and then they analyse them, draw out themes. So this is a diagram that they produce publicly available that shows the stillbirth and neonatal death rates at all of the different trusts in the UK. So here at LTHT, we provide the highest level of care. We have a level 3 neonatal intensive care unit, and we provide neonatal surgery. So we're in that top row. And I've circled LTHT, and for stillbirth, we're very slightly above average, but within that cluster. However, when you look then at neonatal death, extended perinatal death with and excluding deaths due to congenital anomalies, we are an outlier. We've known about this long before it all hit the press in January, and there are some flaws in how we really truly compare to the rest of this group, but I just don't have time to go into this today. Next slide, please. So I met with various obstetricians, midwives, and neonatal doctors to find out what work had been done before, and get a sense of where people felt there could be an area to improve. So we thought about which babies had the toughest time on the neonatal unit, and then to use my background in obstetrics, we decided to then look closer at babies that we as obstetricians decide to deliver prematurely, because we're worried about the mum or the baby, rather than those babies who spontaneously arrive prematurely. I looked at why we made the decision to deliver them early and how the babies fared after they were born. Next slide, please. So I looked at a year's worth of data, and our preterm births are roughly half and half, spontaneous and not spontaneous. And as you can see on the graph on the right, they seem to happen at similar gestations. And there were, unsurprisingly, really 49 different reasons why we made decisions to deliver babies prematurely. And for over half of them, 57%, it was multifactorial. So that pie chart shows the main reasons, and that list on the right of the pie chart is in order of how frequently they came up. So obviously I expect nobody knows what all the millions of acronyms are. So PROM is when the waters break prematurely. So there is some element of spontaneity there. So I didn't include them in the deep dive, but I then looked at the next top 3 causes. So that's PET/HELP, which is a condition caused by the placenta that can make mum and the baby unwell. And there's abnormal antenatal CTG. The CTG is that heartbeat tracing that we do of baby that tells us how they're doing. So if it's significantly abnormal, that tells us that the baby's in trouble. And fetal growth restriction, which is where the baby is much smaller than we would expect them to be. So for the babies that were born for those 3 reasons, their outcomes were significantly worse than the national expected outcomes, which doesn't break them down into spontaneous or not spontaneous. So for our group that we decided to deliver at less than 28 weeks, the perinatal mortality rate was 50%, whereas nationally for all babies born at less than 28 weeks, and as I say, including those spontaneous births, that we would expect the perinatal mortality rate to be 146 per 1,000. For the group between 28 and 32 weeks, our perinatal mortality rate was 10.5%, and nationally we would expect this to be around 31 per 1,000 for all preterm births at this gestation. And then necrotizing enterocolitis, that's a condition that affects the gut in premature babies that has quite significant mortality associated with it. And our rate in this group was 12% compared to that national value of 5.5% at less than 32 weeks. Next slide, please. So we clearly have identified a group of babies that have worse outcomes that we can now focus on to reduce our perinatal mortality rate on the trust. And it was great collaboration really between obstetrics and neonates. We work side by side delivering babies, but actually it can feel like completely different worlds and completely different areas of expertise. Next slide, please. And then challenges. In an ideal world, I would have had this all done before the CQC and NHS England visits came, both obviously to show them what the results were, but also obviously so much work was generated from these visits that both I and the quality team and all the teams were so distracted and had lots of other stuff to do, which meant that we just weren't able to put the time into driving the next step forwards as we would have liked. So then in terms of what we do next, we follow national guidance here at LTHT for screening and monitoring of our pregnant population, but clearly we need to do more, and there are extra things that other units do. I've given a couple of examples there that will involve some working with the sonographers and working with the pathology team. So our next steps really will be to liaise with the sonographers, with the laboratory staff, and create business cases to take these forward and to drive some improvement. Thank you very much.
Thanks, Clodagh. So we won't stop for questions. We'll just carry straight on as we do usually. Millie, welcome. Just tell folks a little bit about you two.
Yeah, so hi everyone. So I'm one of the clinical leadership fellows as well, and my background is a general surgery registrar. So I'm here today to talk about the abdominal pain pathway, which is something we've set up sort of over the last few months. Next slide, please. So emergency laparotomy is a life-saving procedure for sort of several intra-abdominal pathologies, but something that nationally hospitals struggle to deliver in a timely manner. So recent national data showed that we're missing sort of recommended time windows in the majority of these cases. And we know that the faster a patient has emergency surgery, the better their outcomes are. So the question is whether we can improve this service at Leeds. Next slide, please. So we've had sort of multi-specialty input from the start to kind of help try and identify areas for improvement along the whole patient journey. So ED, radiology, general surgery and anaesthetics. And sort of using several methods, we were able to kind of identify key points and sort of to target streamlining care, from which we've sort of developed a pathway for patients who present to Jimmy's A&E with abdominal pain. So eligibility criteria was established for front door and triage staff to kind of prompt sort of early recognition of these patients and to escalate them for prioritised clinical review. Clinicians then decide suitability for the pathway using a slightly more nuanced criteria. And if patients do stay on this pathway, they then have access to expedited CT scans without having to delay for blood results. So it kind of facilitates a faster diagnosis and in theory should allow for earlier intervention, which obviously in this case is theatre. Next slide, please. So we implemented it in December of last year, and in April we were able to kind of introduce a dedicated fellow, so the perioperative fellow, who kind of provided in-hours support for the pathway. So they kind of acted as the point of call from staff at front door and triage, and they were able to kind of provide clinical review, a decision about pathway suitability, and then facilitate the investigations and sort of chase all of that up. So it sort of takes that burden off the ED clinicians. So big question is, has it made a difference? So next slide, please. So we were able to compare 3 data sets, so a control and a pathway data set, which were sort of same time periods, just 12 months apart from each other, and a perioperative fellow data set. So the control and the pathway data sets are all patients who've presented to ED with abdominal pain within those timeframes, who've gone on to have an emergency laparotomy for time-critical pathology, so i.e. conditions where the first-line management is emergency surgery. So for the purposes of this analysis, we've sort of defined that as bowel ischemia, closed-loop bowel obstructions, mechanical bowel obstructions, and perforations. The fellow data set is a little bit different. So it's essentially all of the cases that were referred to them during their time in the role. The patients in that group, just through chance, but don't fulfill the criteria for time critical diagnoses. And the one case that did go to theatre is for a laparoscopic appendicectomy rather than for a laparotomy. So it is for a sort of different operation, but we've included it just for comparison to assess the general impact of someone in that role in kind of the impact on that lead time from door to theatre. So we can see from this straight away that utilisation of the pathway still isn't great. So of all 29 patients in the pathway data set, all of them were eligible for the pathway, but only 5 of them were actually put onto the pathway. So there's definitely still a kind of recognition and pathway activation issue there. Next slide, please. What we've then done is compare specific time intervals between data sets, as well as a kind of global arrival to theatre metric. And for the purposes of this, we've divided the pathway data into patients who were put on the pathway and patients who weren't. So if we just look at the control and the pathway data, we can sort of see that there's a sort of slight improvement in that nursing assessment to clinician assessment time, regardless as to whether they're actually put on the pathway or not. And it is small, but that's the kind of only real point where there seems to have been much difference. And otherwise, there don't really seem to have been any improvements if we just look at the control and the pathway data set, which is a bit disheartening. But where we see the real benefits are after the introduction of the fellow. So once they were introduced, there were improved timings at nearly every stage of the patient journey. So even though it was for a sort of keyhole appendicitis operation, they got from door to theatre in less than 7 hours, which is 4 hours better than any of the other groups. So it's got a real potential to be able to sort of significantly impact on those patients with those time critical pathologies. So it kind of demonstrates that the pathway can work, but it only seems to make a real difference in the presence of a dedicated person to kind of assess and coordinate patients for the pathway. Next slide, please. We've also looked at some other patient outcomes, and again, whilst the numbers are small, it seems to demonstrate that patients who are put on the pathway appear to have better outcomes, so around sort of being admitted to ITU and the length of stay on ICU, mortality, and sort of overall hospital inpatient stay. Next slide, please. So what went well, what were the challenges? So it seems to demonstrate that the pathway can deliver an improvement in care, and staff seem really keen to engage with it, but there seems to be a bit of a gap between the sort of engagement and the fact that what the actual utilisation of the pathway. Because like I said, we've kind of been working with all professions, and that sort of keenness to get involved with it is evident across all sort of professions. There was an unexpected bonus of a kind of improvement in interspecialty relationships as well. So from the working group, shadowing periods were arranged between ED and radiology for resident doctors to kind of be able to appreciate their respective workloads and balancing of demands, which I think is helpful in terms of helping things run sort of more smoothly, both for this and just in general workings. In terms of the challenges, the main thing is about getting it embedded, I think, from our point of view. So we know it works, we know staff are engaged, but uptake is still poor in terms of how often it's being used. So why is that? Is it a volume problem? Is it a sort of being overwhelmed by pathways? There are lots of things to unpick there, but I think which do need looking at. And the other question is whether there are other issues not being addressed by the pathway. So obviously door to theatre covers a whole range of things, and this pathway is very much aimed at sort of the sort of left side of that pathway, so those sort of initial presenting things. And it might be that we need to look at things a little further down the line. Next slide, please. So there's ongoing work around it, and the kind of team are kind of going to carry on with this, sort of trying to get it embedded with a few things that we're going to try and introduce. We've also distributed questionnaires amongst some of the staff in ED, sort of finding out what their experiences are to the barriers, and try and remove them and kind of make it more accessible. And with the data we've got from the perioperative fellow, we're going to try and sort of introduce a fellow who's there Monday to Friday in hours to be able to act as that point of call for the pathway, because that seems to be the thing that makes the difference. And then with ongoing data capture and analysis, we'll see if that has any effect. Thank you.
Millie, thank you for that. So we'll move swiftly on. So B, welcome.
Hi.
Tell us a little bit about you.
So I am an adult nurse by background. Spent most of my time in critical care. So my project is to support the relatively new delirium strategy that was devised by Sean Nynan, consultant geriatrician, and lead nurse Ali Raycraft. And what that's about is ensuring that every patient over the age of 65 that's admitted has a delirium screen, and that if they are positive for that, that they then get a nursing care plan, which seems quite straightforward, but as we had 97,000 inpatients last year, it's a huge task. Next slide, please. So what are the challenges? Well, it can be incredibly scary for patients, and we estimate that probably 20 to 30% of inpatients at any given time are experiencing delirium, and that they are 3 to 6 times more likely to die. So in terms of the definition, delirium is a serious clinical condition characterised by a disturbance in attention. So basically when people are intermittently confused. The problem is that the condition is quite subtle and it can be complex. So we miss about 30% of patients having this. The good news is it is preventable, and we can do a lot more about that to improve patient outcomes. But I think the biggest challenge here is that paradigm shift in thinking. So we have a thing where we talk about patients being pleasantly confused, but it doesn't reflect reality, and it doesn't offer any useful descriptions that can help identify the causes, and it's passive. So what we actually need to do is think about recognising a patient's change in cognition and then doing some active management to change that. So next slide, please. Okay, so in terms of aligning this with the Leeds improvement method, I've just talked about the aim statement. Our process measures, so on the intranet, on the delirium and dementia pages, we have this delirium test, this 4AT, and you can drill that down by CSU and by clinical area to see people's performance in terms of this. Also, the nursing teams every month will pick in a clinical area 10 random patients and audit all of the documentation they have. And then I've done a care plan audit as well. In terms of balance measures, the things that we don't control but will ultimately affect the outcome of this, we also did a confidence survey to see how well, since the strategy came in, whether staff are more confident at recognising and managing delirium. We've also looked at the effects of patient harms and correlating those and the length of stay. How have I done it? It's mainly through a lot of face-to-face training, walking around wards, going to team meetings. I've done some screensavers and lots of other comms. And I think the most important thing is we talk about how culture will eat strategy for breakfast, improvement for lunch, and absolutely everything else for tea. So it's about getting those people who work at the point of care, who are the experts in the reality of delivering care, what they need to do in amplifying their voice to drive some of the strategy and some of the mindsets around the trust. So we created a shared decision-making council. Next slide, please. Okay, so what's changed? Well, when I first started, it was 64% compliance with this 480 on admission, and that has only gone up by 8%, but that's about another 60 patients per month. What we've also found from the confidence survey is that the strategy has improved clinicians' confidence at recognising and managing delirium. So we are making changes to outcomes for patients, but being able to look at those balance measures is quite a lot. We're still computing that, but we are writing this for publication because we are the first trust of this size to do a delirium strategy of this nature. There are a few animations in this Madupe, so if you want to just sort of like click forward. So I've done some screensavers and some sketch notes. If you could just click on that. So you might have recognised that from one of the screensavers. So Pinch Me is the way that we can prevent and manage delirium. If you just click on the next and again. And so I created this sketch note, which has been used in education to really look at the different factors of how we can improve delirium. And then the next two. Click it again and again. So I think the really proud thing, and the next click again if you can. So we've created this shared decision-making council, which is multi-professional and represents most of the CSUs within the organisation. they've met a few times, and I'm really proud of them. And they represent patients' voice as well, with the Younger Shared Decision Making Council, and they presented at the celebration event this month as well. And if I can go to the next slide. So what went well? Gate crashing other people's meetings and study days so that I wasn't putting additional operational pressure on the teams. Also, this 4AT dashboard has been really good at helping teams see where they're going in terms of performance and what they need to meet. And the other thing is that cultural change within the workforce and the Shared Decision Making Council are sustainably making that change. And then just the last slide, I think that is the next. What would I do differently? I did an audit at the end and it kind of resembled a bit of a Gemba walk. So if I'd have done that at the beginning, it might have informed things a bit more. And then it's just recognising that this is a wicked problem and that I was never going to achieve 100%. But every little change makes a difference. And that's me. Thank you.
Thanks, B. So from one end of the age spectrum to the other, Abby.
Thanks very much. I'm Abby Kiley. I'm a paediatric advanced practitioner by background, and my project for the year has been Deteriorating Child and Neonate, with the aim to improve the recognition and escalation of acutely unwell patients. Next slide, please. So as one of the largest children's hospitals in the country, we see and treat children with often quite complex and specialist conditions, and we look after high acuity patients within our ward areas, with wards spread out throughout Clarendon Wing. And this can present challenges around recognising and responding to deterioration. So the challenge was to create a safe system and framework for patients at risk of deterioration to enable anyone that enters the children's hospital to raise concerns and be heard. We want to ensure appropriate and timely care for children who are deteriorating, and also work collaboratively with patients and families, working in partnership so they feel that they are able to raise concerns. And this work links heavily with 2 of the 7 commitments, compassion and team. I think acute deterioration is a really stressful and potentially life-changing event for families, and we need to ensure that we're providing the best experience of care possible, as a poor experience can really have long-term implications for mental health and engagement with future services. Next slide, please. So over the last year, I've designed a programme of work with around deteriorating child and neonate, and Martha's Rule has been a big focus of the year. So we had a full launch of Martha's Rule in Children's in January, with the addition of the patient wellness question within our electronic observations. We are early adopters of Martha's Rule in paediatrics, and we've been participating in the NHSE National Martha's Rule pilot. I've also created a deteriorating child strategy, which outlines a programme of work we aim to undertake, and that's mapped to the CQC safety domains and the RCPCH framework for deteriorating child. We've worked in partnership with families, and we ran the first family workshop in March alongside the patient experience team to get some feedback on our processes. And we've also been working collaboratively, sharing our work throughout the region and nationally. We've published some of our pre-implementation Martha's Rule work, and that's the first data published, which includes a focus on health equity. We're really proud to say that the equity data of those families using Martha's Rule service is reflective of our baseline admission data. And we've also restructured the governance around deteriorating child. So we've got a standalone DP&R meeting, which mirrors the adult structure and has improved our efficiency of working. Next slide, please. So this work is really difficult to measure through metrics. We launched a parent survey in December prior to implementing Martha's Rule, and then we repeated this during implementation and again in March. It's been really useful to benchmark our improvements, and we've had really positive results. So as you can see, the first question, did you feel listened to during your child's stay? 55% of families felt listened to in December, and in March that's increased to 85%. With similar increases in confidence to raise concerns. And then also we've seen a increase in the number of families that don't have any concerns. So we feel we're acting on any issues more timely to prevent them becoming concerns. The comments we received in March, again, have been much more positive. We've still got some work to do. We'd like it to be 100% of families that felt listened to, but we know that we've made significant improvements, and it's been really nice to share some of the comments that we've received with our clinical teams. Next slide, please. So what went well? We've had really good engagement with Martha's Rule, and the clinical teams have really recognised the value and the impact of the work. We've had great collaborative working across Leeds teaching hospitals with our adult colleagues and sepsis and outreach, and we've managed to evidence improvements through our family feedback. We've also utilised digital resources to implement change. So we know that the physiological differences between children and adults, children will compensate and then deteriorate much more rapidly compared to adults. So implementing a patient wellness question, which was to be completed once a day on a standalone form, was not going to recognise deterioration, and it was not going to be of any benefit. So we worked with the digital team to implement the question in our electronic observation system. So we ask it with every set of observations that's done throughout the Children's Hospital. And the feedback from nursing and medical teams has been really positive. Next slide, please. So going forward, we are working to implement the National Paediatric Early Warning Observation System, similar to adults have NEWS or NEWS 2. So we're working to implement this. There has been some challenges nationally regarding the implementation and the conversion of the paper chart to a digital system. So we're working alongside the digital team again to develop this, and our current sort of mock-ups that you can see a picture on that slide really do complement the work that we're doing around recognising deterioration. They're much more visual to recognise trends, and we've got dedicated space within it to record escalation and actions taken in the event of deterioration. So going forward, we really want to drive the work to implement this system within the Children's Hospital. And we also want to start a piece of nursing education work, including implementing a dedicated study day, alongside fully launching our Deteriorating Child strategy. Thank you.
Abby, thank you. And last but by no means least, Pav, something that's really quite dear to my heart as DIPSI, broad spectrum antibiotic prescribing. Tell us about you and your project.
Yeah, thank you. So hi everyone, my name is Pav. I'm actually a dentist by background, but I've spent my year looking at PIP-TAS prescriptions in elderly patients. So the aim of this project was to decrease the number of PIP-TAS prescriptions used in geriatric medicine, so that's with our elderly patients, with a goal of 100% compliance with our trust guidance by August. Next slide, please. So before I started my project, obviously this is an area that I'm not that familiar with. I spoke to lots of people involved with antimicrobial stewardship, and it became very clear early on that within LTHT, we have a massive problem with overprescribing PIP-TAS. So I looked at prescriptions over a 12-month period, and using the Pareto principle, geriatric medicine was identified as a huge overuser of PIP-TAS. I then carried out a baseline audit, and the results of this audit are shown on the slide. Some of the main findings was that there was a lack of consultant decision at post-take ward rounds, and 30% of patients were inappropriately prescribed PIP-TAS in line with our trust guidance, which was updated and introduced specifically for elderly medicine in April of 2024. So focusing on those patients who were inappropriately prescribed PIP-TAS, just under 3/4 went on to our older adult acute admission wards, so that's J19 and J21, and 3/4 of them were diagnosed with sepsis of an unclear source. Following on from my audit, I wanted to get a really good understanding of why doctors and consultants don't follow the guidance that we have. So I carried out a cross-sectional survey, which is based on a psychometric questionnaire of 100 resident doctors and 15 elderly medicine consultants, which is about 50% of the consultant body. This questionnaire really focused on what were the barriers to following our guidance, and from the results of this questionnaire, I was able to come up with some interventions. Next slide, please. So I created a working group. So using discussions at the working group and the results of the survey, along with behaviour change theory, I tested interventions using PDSA cycles, and these are shown on your slides. on the slide, sorry. So, for example, one of the concerns raised from the questionnaire from resident doctors was that they felt consultants didn't follow the guidance, so why should they? So we did lots of work with consultants on role modelling to follow the guidance. There were also lots of concerns raised with gentamicin, especially the use in elderly patients. So I did lots of work on patient safety, promoting the safety, and also the usability of gentamicin. Next slide, please. So you can see from the run chart on the left of the screen that there has been a decrease in the total number of PIPTAS prescriptions used in geriatric medicine. If you just click next, please. Thank you. So we've got a really nice downward trend there. And what that tells us is that our PDSA cycles have resulted in a statistically significant change. Other wins in this project is that we've achieved the lowest number of prescriptions over an 18-month period. You will notice that there are some increases on the run chart. So for example, in April of 2025, there's quite a sharp increase, and that's basically thought to be because we've had our resident doctor body rotate. But reassuringly, that's come back down in May and also June, which shows that our work with our other PDSA cycles has still been of use. Another really important win for this project was that we've had an increase in the consultant decision on post-take ward round. So we're now at 90% of patients getting a consultant review of their antibiotics. So that's been really beneficial to us. Next slide, please. So what went well with this project? So it really has been a team effort. So thank you to everyone who's helped me. Crucial has been creating this working group of frontline staff. So my background is dentistry, but I haven't been able to achieve what I have without the work of an infectious disease consultant, lots of pharmacists based in elderly medicine, and also a geriatric consultant. Behaviour change is really difficult, but we can see from my run chart I have been successful, and that's been because of the multiple different approaches that I've used. What I think has been crucial as well is that I took the time to initially understand what are the barriers for our doctors and our consultants, and instead of using generic interventions like posters and screensavers, the interventions were tailored to our teams to make sure that they were beneficial. Next slide, please. So what are the next steps? So it's been really difficult throughout the whole project to engage with the resident doctor body, and obviously they rotate every few months. So we're still considering what options we have available. We're currently looking at the feasibility of empowering our nurses on the ward who don't rotate to see if we can get them involved with encouraging resident doctors to follow the guidance. And there is a really, really huge issue with the ED department not following older people guidance. So there's still lots of work to be done there as well. Thank you for listening.
Thank you, Pav. So team, you'll see our clinical leadership fellows are multidisciplinary, all stripes, all clinical backgrounds. It's not exclusive to one professional group or another. So just while everybody's thinking about questions, we've got until 1:10 for questions going further on. Can I just ask a general question to the five of you? Biggest learning from a leadership or management perspective in your year? Silence.
Yeah, I'm happy to start.
Go.
I think basically what I've learned is it's not a one size or one style fits everyone. I think different people have different approaches, and I think what I found from talking to lots of different people, working with lots of different people, is everyone's style is different. And I think as long as you stay true to what style works for you and your team, I think that's what makes a successful leader. I think you don't need to see someone and think, okay, I need to have the same style as them, but I think you need to develop what's important to you, what's important to your team, and base your leadership upon that. That's what I would say.
Pav, I think that's really important. I spent my first 6 months as a CMO. Some of you will remember the old Nike advert, I want to be like Mike, and there's that Michael Jordan picture of him leaping and pushing a basketball in. And eventually I came to the conclusion, you better be yourself because it's easier and not as hard to remember. So the authenticity is absolutely vital. Go with you there. And I think I just saw a hand then, B.
I think I've learned the importance of introspection, and that's like knowing who you are and how that then influences everyone else. But I think as a nurse of 20 years, there's a lot of things that I've learned about the career trajectories of other professional groups, like what it's like to be a doctor, what drives certain things. And I think that definitely will support more MDT working for me in the future. So yeah, appreciate the year.
And B, when you say introspection, humility to reflect.
Yeah, I think it's sort of like there is something around being kind to yourself as well, because I don't think we always are as clinicians, and that's so important. But then just getting to know like what's triggering you and why, and sort of like working through that, it means that you don't have a blind spot, and it can be really then clear about what you're trying to achieve with everybody else. So
Thanks, B. That's often some of the most uncomfortable personal work to do. The humility to ask yourself, is what I really believe actually true? I think that's really important. Millie, Clodagh, Abby, anything from you guys?
I'll just add and echo what Pav and B have said, but also a little bit of an insight into the workings of the trust and sort of the wider NHS, and how, you know, what goes on behind the scenes essentially, and how that impacts on your clinical work, and particularly around sort of governance structures has been really useful.
So something around the technicality of how the organisation works. Yeah, and that was all from the day spent with me, wasn't it? No, so you don't have to answer that. Can I just ask everybody else on the call, any comments, questions about the 5 projects you've heard? Lee.
Hi, thanks, Magnus. I thought they were excellent. They're all very diverse, and it was really interesting to hear from all of you, and really important pieces of work. I wanted to ask Clodagh, actually. I particularly liked that you did that piece about, did we make the right decision? That reflection of what was the decision we made? Was it right? What was it doing? I just wondered with that work, if you will, not you particularly, but if that work will be continued, and is it going to include demographic data within it, so IMD data and population data, to look at whether that's changing over time?
Thanks
Great
so much,
question.
Lee. Yeah, great question. And if I'd had more than 5 minutes, a big part of my project, you're absolutely right, was about the health equity side of things, and probably no surprise to anybody that's worked in healthcare, but you know, where people from those lower IMD groups were disproportionately affected and much more likely to have non-spontaneous preterm births. The decision making is always very tricky. You know, it's a big consultant body, then plus registrars making decisions, you know, sometimes in emergency settings out of hours and things. So I considered doing a deeper dive into that decision making itself, but actually it maybe seemed like a bit of a minefield, really. But yeah, absolutely, I've liaised with we've got a health equity consultant midwife that's been doing a lot of work around health equity as well.
Thank you.
Lee, great question. Clodagh, thank you for your answer. I think the EDI lens that we've just discussed is something that we're going to be discussing more and more over the coming year, and being able to apply that to waiting lists, the way we view outpatients, the way we deliver services, because unconsciously and unintentionally, some of the things we do discriminate against those who suffer the most discrimination. And Leeds as a whole, Leeds Place, from an ICB perspective, we're a marmot city, and what that means is we disproportionately focus on those that need the most. I don't think we've got that nailed yet, so the whole EDI agenda is fairly significant. Just a couple of specific questions. Clodagh, you know, when you were talking about mortality per 1,000 nationally versus ours, Lord above that, you know, I'm anxious reading that.
I know, I realised looking at it, I was like, this looks terrible. But I suppose what you have to bear in mind is that those are numbers compared to, you know, we're making these decisions to deliver babies because most of the time because we think it's going to result in a stillbirth, so we should deliver them prematurely. So obviously we are selecting. I absolutely agree. I thought looking at those numbers, it looked terrible, but they aren't. You can't compare them like for like. They aren't comparable numbers. But I suppose it's just worth saying, yes, this is a group that does work more, so we can identify them as where we need to focus our work.
Thank you. And B, just around the 480, I think it's really easy when you hear about delirium to think elderly care wards, when in actual fact, quite a lot of the work that Millie described, quite a lot of the work that Pav's described, we're talking about delirium in elderly patients across the entirety of the trust. It's not just in medical specialties.
No, and I think it probably makes up a significant amount of our inpatients, those that are over the age of 65, in oncology, in settings outside of geriatric medicine. So it is a huge thing to try and push at, really. It's thousands of patients a year.
Yeah. And B, I think what's really important to note, so the work that Sean led on, the work that you've helped with over the last year, we were vanishingly low at the 4AT rates, and we're now second highest reporter of 4AT rates in the country. So the screening tool for delirium, there's only Edinburgh, I think, that are better than us now, so that's great work. And Abby, when you were talking about your results, the thing that really resonated for me was 85% of patients felt listened to. And what I've got in my mind at the moment is the CQC context, particularly in maternity, less so in neonates, but particularly in maternity. We stopped listening to folks. So any intervention that we put in that means we're listening more actively to people gets an absolute vote. And so we're a minute over time now, and that's me waffling. Apologies all. Can I just say, next year we have another group of leadership fellows. I'd like to say thank you to this group. Hope you've learnt loads and enjoyed it. Monday evening, thank you very much. We won't say any more about that, but have a fab rest of days. Can I just thank the KPO team as well? So Madupe for pulling this together with Katie and Natasha. Tip top. Have good days. Have good weekends, everybody.
Thank you.
Thank you.
Thanks,
Cheers.
everyone.
Bye.
Thanks, Magnus.